Hey everybody, Ryan here, and you are listening to The Poison Lab. Today, we have another very special episode of Toxicologists vs. the Internet. We welcome on our esteemed guest, Dr. Jillian Theobald, and do our best to tackle some of the unanswered questions about toxicology or drug toxicity on the internet, and then dive into some clinical cases. For those that are just here for the clinical information, the cases will be starting right around minute 41, so feel free to skip ahead. In this episode, we cover quite a few topics, everything from heavy metals to flower petals, the clinical effects of benzodiazepines on TV watching, potential dangers of Kava lactones, the patient side of receiving ketamine, and honestly, much, much more. I think it's a great episode. Now, for a few disclaimers. While we try to be as evidence-based as possible in this show, the purpose of it is to have a fun, lively discussion around toxicologic and pharmacologic principles, sourced primarily from the warehouses of data in our own brains. So if you happen to identify something that isn't up to date, or maybe we misstated something, please reach out to the show. We'll correct it later. It'll be good learning for everyone. Secondly, it's a great reminder that this show is for educational purposes and not intended to be medical advice. If you have questions about your own healthcare, please reach out to your doctor. Or if you have concerns about poisoning, call 1-800-222-1222 to get 24/7 access to free medical advice regarding poisoning from trained medical professionals. Next, toxicologists frequently manage the toxicities of patients using illicit drugs, and many of the questions on the internet are about illicit drugs. While this provides an excellent venue for us to discuss pharmacologic and toxicologic principles, we are in no way advocating for anyone to use illicit substances. It exposes users to unregulated doses, potential toxicities, and significant contaminants which can cause serious effects. If you or a loved one are struggling with substance use disorder, please call 1-800-662-4357 for access to SAMHSA's 24/7 treatment referral line. Get the help that you deserve. Without further ado, let's jump right in. Hey folks, you are listening to The Poison Lab, a show about poisoning from people who manage poisoning. And today we have another very special episode. It's not one of our normal deep dives into poisonings. We are thrilled to welcome an esteemed guest, and I'm going to say a personal hero of mine, which you'll understand why in just a minute. Dr. Jillian Theobald is an emergency medicine physician, medical toxicologist, associate medical director of Poison Center, and associate professor of emergency medicine. And we are so lucky to be joined by her today for honestly too many reasons. Not only did she get her MD from Rosalind Franklin University, but at the exact same time managed to get her PhD in cellular biology, and then went on to complete 5 years of postgraduate medical training, becoming one of the most amazing emergency medicine physicians and medical toxicologists that I have ever had the opportunity to work with. And despite an incredibly busy clinical schedule, finds the time to help run a poison center, caring for poison patients all throughout the state, as well as just be one of the most hyper-productive people I have ever met. And despite the many accolades that Dr. Theobald has, she still manages to be one of the most humble and wonderful people to be around. So thank you so much for joining us today.
I'm a little bit of an a-hole, let's be honest.
Yeah, but in the good ways. In the ways that are fun. So welcome to the show, and thank you very much. We really appreciate it. How are you?
Good. I've been in the thick of virtual kindergarten, and that's been pretty amazing. Not so much. So that's been taking up a lot of my time lately.
What is the curriculum of virtual kindergarten?
So it is a Google Hangout for 8 hours a day. They actually get virtual gym, which is quite hilarious. And to see my kid doing jumping jacks in my dining room. But they start out with reading and phonics and writing, and I had to bribe my child with a lot of gummy bears today. I promised him 16 if he would write me 3 sentences.
Ooh.
Yeah, I know.
And are these Haribo gummy bears, or are we talking?
Yes.
Oh, of course.
Yes. Then he got mad because I ate the rest of the bag. So.
Well, that just means you have to do more jumping jacks than him.
That's right.
Well, excellent. Well, I cannot even fathom the challenges that brings up. So thank you for taking the time out of proctoring virtual kindergarten to join us today on the show. We
It's
greatly.
actually my pleasure. I need a break.
Now, the show, as some of the listeners have maybe heard in our past episode where we had Matthew Stanton on the show with us, is broken up into 2 segments. And the name of the show is Toxicologists versus the Internet. This is our second rendition, where we do our very best to answer some of the strange questions that surface themselves on the internet regarding the toxicity of drugs or drug interactions or etc. And then the second part of the show, we jump into trying to work through some toxic differentials for some cases that are sourced from the American Association of Poison Control Centers fatality reports. And it's good learning to see how some severe poisonings might present themselves. And then hopefully a clinician would be able to identify it themselves. But before we go on, before we jump into all the like hardcore toxicology, maybe we could share like your favorite toxicology fact. Did you have a tox aha moment where you're like, wow?
No, and that it's funny because so I don't remember who I was talking about with this lately, but looking back, like when I chose toxicology, I did it like very calculated in a way because I accidentally got pregnant my intern year of my emergency medicine residency, and I had my first kid in November of my second year, and I was just like trying to survive like having a kid in residency,
right?
And I had spent 9 years in medical school, like doing an MD and a PhD, and I was like, the F am I doing a fellowship? Like, I want to get a real job. Like, I'm tired of being a professional student. And it was right around the time, like when I was coming into the beginning of my third year, and I was like, well, when all this data was coming out about burnout and emergency medicine physicians being like the most subject to that. And so I started to really think about, am I going to be okay just logging out shift after shift, 10, 15 years from now? And I was really worried I wasn't going to be. And I said, oh my God, what am I going to do? And then I just was like, well, because I hadn't done my toxicology rotation yet, because that was in our third year.
Right.
And all of my favorite people were in tox, and my PhD was in cellular biology. And so I really liked like down to the cellular level.
Good fit.
Stuff. Yeah. And so I was like, well, this makes sense. And it's one of the few fellowships that really expands your scope of practice. And so that was why I liked it. And I think the most interesting thing for me about it isn't like a single fact or a single case. But like, I am never surprised by what people do, or I'm always surprised by what people do. And so like, there's nothing beats the stories. Nothing beats the stories that people come up with or what people call us for. Like one of my most favorite, I think we were on shift together where we got a phone call from a woman who was a video producer producing a film down in the Amazon. She called us from her cell phone, and she had hired these 2 guys to like drive her or boat her around the wetlands or the river down there. And they would park their boat and they would go off into the rainforest to take videos, and they would throw the battery over their shoulder and carry it with them. And she said that this guy started to get burned from the battery acid. The question for us was like, what antibiotics she should buy him at the store. So,
why do they even have that?
I know. So like, stories like that, nothing beats stories like that. And
you definitely get some interesting stories. You're jogging memories of people calling me because they injected magnesium and they thought they were trying to inject meth, and I don't know, you just hear
it starts with the same lever. It's fine. It's okay. And that is what makes like toxicology so fun. And so in spite of being, like calculating and more out of fear going into this specialty, it turned out to be like probably my most favorite part of my job, honestly.
All right. Well, I think that's great information for anyone who's interested in pursuing medical toxicology as a career. So thank you. And with that, I think we're ready to roll into our next segment. Let's dive into Toxicologists versus the Internet, where we do our very best to answer some of the many questions on the internet about drugs, toxicity, and toxicology. Would you like to ask the first question, or would you like me?
I don't care.
I'm going to ask this question simply because I had never heard of this, and I still don't know that much about it. So the question, this is reddit.com r/askdrugs. Here's the question. What is it like taking a GABA antagonist? Have any of you ever had beneficial effects from one? This is a question that I was very confused about because I had never heard of a GABA antagonist before.
Isn't that like picrotoxin?
Well, yeah, I have not heard of pharmaceutically available GABA antagonists because picrotoxin blocks chloride in the ion channel, I believe, right? Prevents it from
entering. I think so. Because I thought that was what is often used in the lab. As an antagonist for the channel.
Yeah, that would make a lot of sense. But have you heard of a pharmaceutically available
no.
GABA? Yeah, neither had I. So I did a little bit of research, and there is this drug called Fasoracetam.
What?
Yeah.
Is that like the antidote to levetiracetam?
Right.
Yeah.
And I didn't even know where to find this. It was actually posted by another person on this forum, which is how you know that this is the cutting edge of toxicology. We're as toxicologists, you're always one step behind the internet in what they're doing. But yeah, a user posted, take a look at Fasoracetam, which acts as a GABA B blocker, very fast and effective. Which, anytime I hear the words GABA B blocker, that's terrifying to me because it draws up, it conjures up baclofen withdrawal to me, because that's a GABA B agonist. And now you got a GABA B blocker. And it turns out that this was actually studied for a certain type of vascular dementia, but it didn't prove to be effective, so it wasn't approved by the FDA. But now it lives basically as a nootropic, so you can buy it online. Fasoracetam powder, 1 gram, very similar to
nootropic.
Right? Yeah. Nootropic meaning was once featured on Joe Rogan's podcast,
or on the Dr. Oz show,
But this is really so. You can actually buy this online. It reminds me a lot of like the Phenibut kind of compounds, just weird stuff that people are getting into that they really shouldn't and probably needs to be more regulated. I couldn't find any case reports of any actual overdoses, but being a GABA B antagonist, I feel like you would eventually see, I don't know, seizure or just severe like dysautonomia, kind of like GABA B withdrawal. So
what would be the therapeutic benefit of that, especially even in vascular dementia?
So
does it preferentially block presynaptic or postsynaptic GABA B, or is it
great question, not a clue. Also, I have zero ability to assess how this would affect vascular dementia. But somebody else brought up ginkgo biloba, because that is also a GABA antagonist. So the role of, so here we go. They brought up ginkgo. It says the role of GABAergic antagonism in the neuroprotective effects of bilobalide, which I assume is the
say that again. I love that word. Bilobalide.
So they were saying that they take this GABAergic antagonist, which in ginkgo, and this is maybe the same theory, which then promotes, wakeful, anti-GABA, a little bit of excitatory, but it also causes upregulation of your GABA receptors. So it's a way, they were saying it's a way to, because, it kind of makes sense. if you chronically inhibit stimulation, then you upregulate, as opposed to chronically stimulate, you downregulate. So I thought that was interesting. Maybe there's maybe they're trying to upregulate GABA B in some way. I don't know, but I just thought it was something I'd never heard about. So if anybody has a case of Fasoracetam overdose that they'd like to email to us, we'd be thrilled to hear from you. It is your turn.
Okay. I thought this was really interesting because this is another thing that I find fascinating is when people try to self-medicate. So this is one of the questions. It says, is it safe to take Kava while tapering benzodiazepines?
Interesting.
Yeah.
Oh, man.
So the follow-up question is just like a clarifying one. It says, since Kava acts indirectly on benzodiazepine receptors, is it safe or maybe even helpful to use it while going through withdrawal / a taper?
All right. So full disclosure, the mechanism of Kava is escaping me. I'm assuming it's acting indirectly as an agonist and maybe not an antagonist, I would hope. In which case, yeah, I wouldn't recommend using a antagonist compound. I'm going to assume Kava is an agonist. Can you confirm that?
Well, so Kava is a plant, right? And most plants don't have, a single active compound. Usually there's a lot of things within it. So the mechanism of action of Kava there's like 18 different, lipid soluble compounds in there that can have effects. And some of them they inhibit the reuptake of dopamine and norepinephrine, but then they modulate the benzodiazepine receptor. And there's 10 or 12 different proposed mechanisms. So what that modulation is, nobody really knows.
We don't know if this is good or bad modulation.
Correct. But there was a Cochrane review that looked at Kava for the treatment of anxiety, and it actually outperforms placebo. So there is some benefit for taking Kava for anxiety. The interesting thing, though, is that there's different preparations that are made from the plant. The roots and the root stems are where most of the Kava, like the beneficial, the psychoactive components are. And then up higher up is where in the leaf part is where they're not even barely there at all. And then there are some toxic compounds in the leaves.
But that's interesting because usually in plants, a lot of them, we think of the roots as having many of of most of the toxic components.
And so there was, it was actually taken off the market in the early 2000s because there was 70 plus reports of hepatotoxicity.
Wait, Kava was taken off the market?
Yeah. And then in, I would say maybe 5 or 6 years ago or more than that, it was put back on in some places because they think that the reason they had hepatotoxicity was more from aberrant preparations, where it was more from the actual stem of the plant, not the root stem and the roots. And so they think it was from that. But so what modulation means, I don't know. Oh, I will tell you this. So the modulation doesn't affect benzodiazepine binding. So they looked at flunitrazepam, I think is how you say it. They looked at binding of that, and Kava didn't affect it either way.
Interesting.
So it doesn't change the binding of benzodiazepines to the receptor, but it modulates the receptor somehow to make people less anxious, because that's the clinical effects of it.
That would make me think that it, similar to benzos, enhances chloride permeability if it has an anxiolytic effect.
So what do we think? What do you think that it would be safe or even helpful? I think it actually could prolong the withdrawal and taper phase.
Well, this is I think it probably would, because the whole purpose of the taper is to slowly reduce stimulus so that you can upregulate your GABA receptors.
Yeah.
So if you're continually stimulating, you're probably going to prolong your taper because it's going to take longer to upregulate. But this is also just what never makes sense to me about how we treat alcohol withdrawal. Like, you're in withdrawal because you've downregulated all your GABA receptors with alcohol. And then how do we treat you? We continue to stimulate your GABA receptors with benzodiazepines. Like, that's not going to facilitate you up-regulating your GABA receptors. But, it's, they're non-hepatotoxic, and you can do a more controlled taper of your dosage. So I understand, and we don't want you to seize or anything like that. But that's why I'm a big fan of adjunct therapies like ketamine or clonidine on top of benzos, so that we can sort of stop pressing so hard on the GABA receptor pedal and allow you to upregulate your GABA receptors. Yeah. But anyways, as for Kava, or if it enhances chloride permeability, then it probably would be safe. But you're just using another GABA agonist to treat a GABA agonist. And
yeah. And I think too, like, so safety is always an issue, right? Anytime you're having these plant-based extracts that you're ingesting, because you don't know dose. Right. You don't know which of the 18 kava lactones you're trying to isolate and utilize. Mm-hmm. And then you also don't know exactly how that was extracted from the plant. Like, did they actually use the proper part of the plant? Are you putting yourself at risk for hepatotoxicity, which we know is a possibility based on prior case reports? And most of these herbal extracts or supplements are not regulated. And so I think the safety issue isn't necessarily like at the mechanism of action or pharmaceutical issue. It's more of, you don't know what you're actually getting. Are you actually getting the kava?
Well, exactly. You're probably getting 40% diazepam, a little bit of goat thyroid, and maybe like one little ground up piece of kava. So that absolutely. And that's why, you got to be very careful about what's going in any non-FDA regulated substance that's going into the body. And if you're on a taper, it's clearly in, you're in a relationship with a healthcare provider who's doing this taper, and that kava should be, if you're using something medicinal, that should be as well on the radar, and not something you're taking clandestinely and suddenly you have, a bump in your LFTs and we don't know why. So, cool. Awesome. Well, thank you. Good question. I have not looked into kava recently.
Me either, which is why I picked the question.
Yeah, that's a great, right? Well, this one was just funny. I don't know. I thought it was interesting. This one is not even that pharmacologic, but it did bring up a good point for me that I just find fascinating. It says, K-hold 8 months ago, and life hasn't felt the same since? ? And here's the
well, maybe they got their depression improved by their ketamine dose.
Right. So this guy says, hello, Redditors. I've been using ketamine recreationally for probably 3 years. I never built a crazy tolerance because usage was always spaced out every 2 to 3 months. K-holing was never really the objective. 8 months ago, I went into the deepest K-hole I've ever personally experienced, dipping into a new version of understanding which reality was the correct one. The thought of me traveling between bodies opened a sort of Pandora's box for me. Nothing really matters. Life's not even real. It's just how we perceive it in our minds, and everyone is perceiving it differently. Interesting. And I do think there is a degree of truth to that, at least in that each individual's biased perception plays a large role in how we interpret the reality around us. Everyone has a little bit of a different reality. So I guess there's some insight to that, I think. And then basically says, my question is, have any other psychedelic users had thoughts like this, and how do you counteract these thoughts, anxiety-inducing emotions? So I think this is K-hole-induced nihilism, and I'm sorry for this person that they're experiencing that. I don't recommend people use unregulated psychedelics because it can trigger probably some pretty severe psychological trauma. But this is why I bring this up. This is a drug that we give to people every single day.
All the time. My favorite. I'm going to splint your fracture. I'm going to give you a little bit of ketamine.
Yeah. Oh, no. But we give people a lot of bit of ketamine. We dissociate people all the time in the ER. And how many of them, I mean, I'm talking 5 to 10 patients a day coming in and just going to another realm of existence and then coming back. And I can't tell you the amount of times afterwards, one of those sedations, they're like, I love you guys. Oh, my life is amazing now. I would love to see like a quality of life study like do a short form 36, like 6 months after they come to the ER for a reduction, if they got ketamine versus another drug, and see if this is some kind of like a lasting impact.
So this just came up today about like the S-ketamine or the desketamine that they're doing, like single time doses.
Yeah, the S-ketamine.
And I was like, I wonder what dosing they're using. And so I looked at the S-ketamine dosing, and it's a single dose of 56 milligrams. And I was like, for me, that's almost 1 milligram per kilogram. That's a big dose. You know, it's interesting. I've seen the range of reactions, like where patients are like, don't ever give me that again. I don't feel right. I don't feel weird. I have people who hallucinated moths in their room. Yep. I had a family, a son and a wife come out, and they're like, we have never seen my father so happy. What did you give him? He has been like unhappy and depressed for years. And like in the last 10 minutes, he's been like joyful. Like what happened? And I'm like, what?
It is wild. Also, I just saw the brand name for S-ketamine. Spravato. That makes me less depressed already. Spravato. That's good.
Sounds like a car.
Yeah. Right? So, well, I do bring this up because, people have a very wide, and some people have emergence and very severe negative reactions to it, but it is gaining it's FDA approved for severe treatment refractory depression. And similar to other actually psychedelics that are used under medical supervision, psilocybin has a lot of data for use in severe, but that's a complete other mechanism. That's a tryptamine versus this is an NMDA receptor antagonist. But clearly, there is some kind of an effect that is lasting with these. And I'm only bringing this question up.
I wonder if you get the same effect with like dextromethorphan in like the high doses, like when they get the third or fourth plateau.
The fourth plateau. The skittlers, yes, who are taking or robotripping. that is and treating their depression at the same time, apparently, or risking, torsades, but same diffy. But it would be in theory the same. And they both are. So dextromethorphan, actually, there's a great study from my favorite journal ever, the Journal of Scandinavian Anesthesiology. And they did this study because ketamine, we use it for neuropathic pain all the time. So they were like, hey, dextromethorphan's an NMDA receptor antagonist. Let's take all these ED patients and give them 270 milligrams of dextromethorphan and then discharge.
Oh, shut up. Really?
Yeah, but it worked to treat the pain. I got to imagine quite a few of them dissociated. I don't know if that's the route I would go, but so I do bring this up because I read a great piece a while ago. It's actually a writer who has severe treatment refractory depression and was one of the first people to do an intravenous ketamine clinic for depression in Texas. And he wrote about each one of his dissociative experiences. And he's a very gifted writer. I'll put the link in the show notes. But it's fascinating to me. Like he really describes what he goes through each time he got ketamine in this like IV controlled setting under medical supervision. And the fact that this is kind of what we're putting patients through in the ER sometimes when we're just doing a reduction is mind-blowing. So I'll put this guy's story in the show notes. I thought it was really well written. And I think it's something we don't think about a lot when we're giving these people this truly interesting drug with a lot of different effects, maybe some that we're not expecting when we're trying to treat their acute pain.
I have an equal one that I thought was funny.
Yeah. Oh, yeah.
Why do benzos reduce boredom? I clicked on this because I was like, why are they, what? And so it goes, I remember getting a huge ton of diazepam prescribed to me when flying to America. 200 tablets of 2 milligram tablets.
I had no idea. Diazepam to fly to America.
Yeah. So I had no idea what benzos were or how addictive they could be. So it's not a case of preconceived notion affecting my experience. I just thought these were sleeping pills. When I came back, I still had enough tablets and took them. I found that I could just stay and watch TV and not get bored. I notice now how that's unusual. I've never been able to do that as an adult, but only as a kid. I couldn't sit down and watch something for 40 minutes without changing the channel. But for some reason, benzos reduce boredom.
Wow. I
And then the question is, what's the pharmacology of this?
This is also a great reminder to prescribers that you should not give people more drugs than they need. This is why we use like short courses of opioids. Otherwise, they just start taking them to watch TV, and that's really not what they're recommended for.
Yeah. Well, I wonder if it just, you know how sometimes when you're just so tired, like when I'm so tired, like I go out and run like 10 miles or something, and I come home and like it's just easy for me just to sit there. Because I'm too tired to think of anything else. I'm too tired to, like, you know, go up and get this and go and do that and think about this. And I don't know. I wonder if that is like similar to taking a bunch of 2 milligram diazepam tablets.
I think it is. This is going to send us down a rabbit hole. So I'm a very big mindfulness believer and observing of my own thoughts and et cetera and whatever, because I'm very bad at it in general. So I have to practice it sometime. And, you know, you'll notice one thing is probably anxiolysis. People don't like to sit down and watch TV because they have this weird nagging feeling of like, hey, I should be doing something else, right? Or like, hey, I could be productive. This probably, you know, quells that little thought process. Or you'll be sitting down and then 15 other thoughts will come in and you're not, you know, focused and present in the moment. And I think it's called your default mode network is how it's referred to, but you know, all the different thoughts that are rushing through your brain at any moment. And this kind of shuts that down and probably lets you just be more focused on exactly what's going on in front of you. That's that's my Zen take on the pharmacology here. No real science on that one.
Part of me also thought that maybe he just or she just needs to find better TV.
That's true, because there's some great shows that you do not need benzodiazepines to enjoy.
Well, and there are some horrible show. My daughter made us watch this Italian Christmas show that had English dubbed over. Like it was so bad. And it was like the Italian Christmas witch.
Ooh, that's very bad. All right. Here's a good one. This one is actually talks and not just us talking about random subjects. So giving the listeners what they've been waiting for. Are beta and alpha blockers safe for long-term use with stimulants? I'm going to assume he's inquiring about prescribed drug regimens. If he is not, I would hope that they're not trying to mix alpha and beta blockers with illicit stimulants, as that sounds very dangerous. We would not recommend anyone use illicit stimulants. The question itself says, I know stimulants aren't good for the heart long term, but do they cause any horrible reactions or anything with beta alpha blockers? I read about one person who OD'd on cocaine and propranolol, but people are saying that's just a myth perpetuated by an anecdote.
Start at the beginning. What was the question?
I think what they're getting at here is the cocaine chest pain conundrum. Cocaine both releases our stimulant or catecholamine neurotransmitters, and those both vasodilate and vasoconstrict. And if you give somebody a beta blocker, specifically one with beta 2 blocking properties, you block the vasodilatory properties of cocaine, and you get unopposed alpha stimulus. So you actually just constrict all your vessels, and it can lead to coronary ischemia. So that's why the traditional teaching is to not treat cocaine chest pain with beta blockers. Now, stimulants release kind of the same things. They release your norepinephrine, dopamine, epinephrine, or prevent their reuptake, or etc. So let's say you're chronically on, dextroamphetamine, and you're on labetalol for, say, treatment of hypertension. Is that safe together? Which is not a great hypertension drug, but or they're on Coreg for heart failure.
Then they shouldn't be on Adderall.
I don't disagree, but believe me, as a pharmacist, there are many people with inappropriately optimized medication lists, and I understand that there are things.
I think there's way too many people that are on that.
Yeah,
I've seen so many people come in like with these tachydysrhythmias, and the only medication they're on is Adderall or Vyvanse or whatever, and they're like, in their 20s and 30s.
Well, one thing we can at least address here is his statement. Well, I heard somebody overdosed on cocaine and propranolol, but I heard that was just a myth. propagated by an anecdote, but that is absolutely not true. This is one of the things that we actually have data for. And this is a great time to shoehorn in a landmark trial that anyone interested in tox or EM should know about. And that is going to be potentiation of cocaine-induced coronary vasoconstriction by beta-adrenergic blockade, published in Annals of Internal Medicine in 1990 by a Dr. Lang. And this is just a wild trial because what they did was take people who were stable and had a little bit of chest pain and who were going under a left heart catheterization anyways. And essentially, they randomized you to either to receiving intranasal cocaine, 2 mg per kilo, or saline right before undergoing catheterization. And then when they were in there, they injected intracoronary propranolol. So I don't know how they got this approved for IRB. You have people who already have chest pain, and then you're going to give them cocaine and then shoot beta blockers into their heart. So this is truly a cowboy study. So props to you, sir. And I hope everyone turned out okay. But basically, the patients who got cocaine and propranolol at the same time had more significant coronary vasoconstriction, demonstrating that propranolol was increasing the amount of vasoconstriction that occurred by blocking the beta-2 effect. However, propranolol is kind of a unique beta blocker in that it's beta-1 and beta-2 blocker. There are drugs like labetalol that also have alpha blockade and would not cause this unopposed alpha constriction. And this has actually also been shown in a very similar study done 3 years later, where they took patients getting a left heart catheterization, gave them cocaine, and then gave them labetalol. And labetalol did not increase the amount of vasoconstriction you saw with cocaine compared to those who just got saline. So the authors of that original propranolol trial, as well as a few others, have come out saying that it's probably safe to use non-selective beta blockers that have both beta and alpha blockade. But this is still kind of hotly contested. We don't have a lot of large data. It's all based off a lot of these catheter studies or animal studies. So we do know it's probably going to worsen constriction if you're using a beta-1 or beta-2 selective beta blocker, and that could cause some decreased coronary blood flow. But if you're using one with alpha blockade, I've even seen some reviews of how to deal with stimulant toxicity actually say that labetalol and carvedilol are safer. And I'll put the links to all 3 of these studies, the review for amphetamine toxicities, as well as the intracoronary studies in the show notes. I have had a case when I was rotating as a resident in the CI, a cocaine user who had a myocardial infarction. They came out right after you have an MI. Usually they had stenting done. And usually we want to start beta blockade and reduce oxygen demand, but they were all worried because he was cocaine positive on urine drug screen, which is a whole other thing. That just means he did cocaine, not cocaine. But we ended up going with labetalol just because it had alpha blockade alongside it. So it would, in theory, also prevent coronary vasoconstriction. So I thought that was an interesting case and a good way to shoehorn in a classic landmark study. For this person's question, we don't really have a good answer. Beta blocker, alpha blocker might be better than beta blocker alone based off animal data in terms of risk of ischemic coronary vasoconstriction. In terms of other cardiac outcomes, I have no idea. I don't know why you're trying to take stimulants. So if they're not prescribed, please do not. If you're in the unfortunate situation where you're on a stimulant and also have to be on other drugs that might interact, well, that's a great reminder that this isn't medical advice and you should be talking to your PCP. Do we have another question or should we jump into cases?
I have one more.
Yeah. Oh yeah. Let's do it.
Because I had to figure out what this was. Can I take Blue Chew and Phenibut on the same day?
All right. First off, you said Phenibut and I'm sad because I hate that compound. Phenibut, for what people don't know, is Russian baclofen. You buy it on the internet. It is maybe 10 to 30 times less potent as baclofen, but people take it 100-fold times the dose. So, and they usually get addicted to it because it's a GABA agonist, and then you get GABA downregulation, GABA B specifically. And the withdrawal is incredibly difficult to manage. With not a lot of evidence for how to do it, and benzos, barbiturates, and baclofen are typically employed in trying to get control of people. So, Phenibut, I'm gonna go ahead right now and say no, it's not safe because you're taking Phenibut in the first place. What is blue chew? I'm going to hypothesize that that's PCP. Is it PCP?
No. What blue pills do you know that are out there?
They chew them? I'm just trying. I mean, well, you know what?
Viagra.
Yeah, I got to assume this is sildenafil, so this is a phosphodiesterase inhibitor. Actually, they generally don't have a lot of drug interactions, and they wouldn't have one with, so this is Viagra. They do have like 2 or 3 very important ones, but overall, there's not a lot. So one, Viagra you want to avoid with other nitrates or people who are taking like nitroglycerin for, angina or anything like that. Because phosphodiesterase is the enzyme that metabolizes cGMP, which is what basically nitric oxide produces. And cGMP is pretty much what dilates your blood vessels. So if you're on a phosphodiesterase inhibitor, you will not break down cGMP. And if you take a nitrate, you will increase cGMP production. You get a synergistic vasodilation and hypotension. And that's why you're not supposed to take a nitrate within 24 to 48 hours of certain Viagra, Cialis, all those good guys. But Phenibut, I guess I wouldn't hypothesize there to be really any interaction there, except for maybe the fact that the Phenibut is not FDA regulated, so it could be 50% nitroglycerin, and we would have no idea.
Probably. I would say probably is the answer to that question.
Yeah, probably. My next question is, why are you on Phenibut? What are you doing? Stop it. Stop being stupid. All right. That was a good one. I like that. I had some more fun ones about amphetamines, but we talked enough about speed and ketamine. And all right. So we're going to move on into the next segment, and we're going to do some cases. So one of us is going to read a case of a fatal poisoning to the other without revealing what the poison is. And the other can work through their differential. If at any time you have questions about the case, you can stop, ask questions, or kind of, if you want to talk out what you're thinking at the moment, feel free to pause me. And hopefully this will give other listeners a good idea of the kind of things that might present in this pattern or how we might rule in or out different things. So, scenario. A 22-year-old was found on the ground after slitting wrists and jumping from a second-story balcony. EMS found oral bleeding and was unable to establish an airway during transport. Patient has a past medical history of bipolar disorder, previous suicide attempts. In the emergency department, his blood pressure is 135/80, heart rate 120 to 140, satting 70 to 86% on room air. His temperature is normal at 36.4. Initial laboratory demonstrates normal sodium chloride, potassium. His bicarb is 21. He does not have an anion gap. His BUN is 15 and his creatinine is 1.4. He has a glucose of 215, an elevated white blood cell count at 19, and his INR is 1.3. In the ED, blood was suctioned from the airway prior to intubation, and a gastric tube returned blood after it was placed.
What's on his med list?
Nothing on the med list. We have no meds on his list. I can say, oh wow. I can't say. So a patient jumped out of a slit wrist, jumped out of a second-story window, was found with blood in the mouth, couldn't get an airway in the field, showed up to the ER. Essentially, normal vitals, low bicarb. He's tachycardic, and those were like an immediate BMP. So what we don't know how things were evolving. He was intubated and got a ton of copious blood out of the OG tube they dropped after intubation.
I wonder if he swallowed what he slit his wrists with.
There is no foreign objects on CT, but I will say CT demonstrated pneumomediastinum, right lower lobe pulmonary aspiration, extensive intraperitoneal hemorrhage consistent with esophageal and gastric perforation.
He must have had a caustic ingestion as well. Drano, extra strength.
I think that's the ding, ding, ding. Acute alkali drain cleaner, which he drank before slitting the wrist and jumping off the balcony. And
guy was serious.
Yeah. So just like you said, obviously this was a caustic based off of his esophageal and gastric perforation, which you could get something like that from a foreign body, but it probably wouldn't be global. But yeah, he had pneumomediastinum, extensive intraperitoneal hemorrhage. And so, of course, this is what I couldn't tell you. The patient received tranexamic acid and blood products, although maybe that wouldn't really give it away. He was just very bleedy. I think he was in DIC from bleeding. Like a coagulative, consumptive coagulopathy. Surgical exploration revealed extensive liquefactive necrosis of nearly all internal organs, which were judged non-survivable. That's aggressive. Yeah. So he melted the inside of his gastric tract and chewed all of his internal organs. That is so sad. I feel bad for them. But it brings up the liquefactive necrosis of alkalis as opposed to the coagulative necrosis of acids. Soap, as we know, is made out of a polar head and a lipophilic tail. The lipophilic tail kind of surrounds fat and grease, and the polar head is a hydroxyl group that gets dissolved in water. So you make soap by adding a base, which has a hydroxyl group, to a fatty compound like human tissue or possibly vegetable oil. I used to make soap at home. It was kind of fun.
What?
Yeah. I have
Why?
I don't know. I have like a little OChem set. I used to make.
Did you watch Fight Club and then decided you wanted to do that?
No, I did watch Fight Club and I did think I was edgy, but it's not why. But it was pretty cool. It was fun. You make little globules. It was just fun. I used to make sodium acetate and stuff like that. But so if you add a base to your body, which is made a large amount of your phospholipid bilayer of your cells, which is fat, you siphonify your tissue, and it just causes deep tissue burns because you're able to continually penetrate through more tissue. So kind of sad, but good, great, spot on in the alkaline ingestion. Bad outcome. Okay.
80.
Yep. Let's hear it.
So a 31-year-old female was hospitalized with a 2-week history of abdominal pain, painful, 2 weeks, painful peripheral neuropathy, new onset hypertension.
Thallium. Is it thallium? Oh, wait, keep going.
No.
Did she lose all her hair?
No.
Really?
She had high blood pressure and elevated LFTs.
I mean, that would, so abdominal pain, chronic neuropathy.
It could be arsenic.
Right.
It could be pretty much any heavy metal.
It absolutely could. I just guessed.
Sure.
So, all right. The hypertension, so that doesn't ding with me.
Hypertension actually can be pretty common after mercury exposures. Especially inorganic mercury, because it can cause kidney disease and then lead to high blood pressure. But yeah, no, but so like painful peripheral neuropathies, that's pretty common in any sort of heavy metal exposure, like arsenic poisoning. Mercury's not necessarily, but you can get even lead poisoning causes peripheral neuropathies.
Right.
Although that's more motor based than sensory based, but
thallium, I always hear the dying back neuropathy. That's like the.
Yeah. So do you know the triad of thallium poisoning? So
thallium, you have neuropathy, you have alopecia. It is one of the most effective hair removal agents known to man. Something about constipation. Well, it's alopecia, neuropathy, and an upset spouse or roommate, I thought was.
Yes. Thallium is actually really interesting because it is a common murder weapon. It's a very common way to kill somebody or poison somebody, which there's actually some really great cases. There's an MMWR report from, I think it's Israel or Iraq, where at a soccer club, a cake was poisoned by thallium, and it was sent to like a board of directors meeting, and they ended up not eating the cake. But 2 members of the board of directors cut it in half and took it home. And and so all their families ate it. And a couple people, it was pretty bad. Like a child died. And then there was another great case that the people from New York published, where this neighbor was angry with these girls that lived in the same apartment complex, and he injected thallium into some marzipan balls and then sent it to them. Mm-hmm. And 4 of the girls ate it, but really only 2 of them got sick. And in the case report, they had a X-ray of the marzipan balls, which was kind of fun.
Oh, wow. That's awesome.
Yeah. So
what happened with it? Well, so what's the third?
It's the neuropathy, the alopecia, and then the abdominal stuff.
And abdominal. I feel like thallium, I don't know why this is dinging in my brain, but I've heard it's more constipating compared to a lot of the other ones cause like hemorrhagic gastritis with acute ingestion.
Right.
This one is more.
So lead and thallium are different. They cause abdominal pain. It's more colicky abdominal pain, and it's typically associated with constipation.
Yeah, lead ileus.
But the rest of the heavy metals or metals are more like cholera-like or hemorrhagic gastroenteritis.
Can we hear the rest of this case? Should she get Prussian blue? All the good stuff.
Yeah. Well, so anyway, she comes in and they don't know what's going on with her because all she has is abdominal pain, neuropathy, hypertension, and elevated LFTs. They wrote transaminitis, but I'm not going to say that word.
Yeah, that is a sin.
Her only past medical history was PCOS, so polycystic ovarian syndrome. Labs were pretty fine. Her creatinine was 1.2. Her AST was 170. ALT was 381. Her renal ultrasound and MRI were fine. She got more and more lethargic and ended up getting transferred to a tertiary care center after a couple weeks. And when she arrived, she had garbled speech, was difficult to awaken. She was developing alopecia at that point and a skin rash. And then her encephalopathy got worse. She was intubated. Her LP was positive for HSV1, so herpes simplex 1. And she was treated with IV acyclovir. And then she had a pretty impressive workup. She had ascending areflexia with EMG proven motor predominant peripheral axonopathy. She even had a brain biopsy. And on day 16, her urine thallium was crazy high.
Wow.
She started on dialysis.
Or just a spot?
That was a spot. And then the next day they did a 24-hour.
Interesting.
It was like greater than their detection limit.
Did they do a blood too? I think this just throws everyone off. It's like, when do you do blood? When do you do urine? Blood's more for acute, and then it distributes, right? And better exposure is 24-hour urine. Yeah.
In general, for most heavy metals, aside from lead, it's best to do a 24-hour urine collection. Right. So they did hemodialysis, multidose activated charcoal, and then they finally were able to get Prussian blue 3 days later, and they ended up giving it for 16 days.
Wow.
Patient never recovered. And then they did comfort measures. Man. And they don't know what the source was.
No, really? Mm-hmm. She lived alone? Yeah, that's tough. Mm-hmm. Dialysis, MDAC, and Prussian blue. Yeah, what else can you do?
I think the damage was done.
And I always think it's interesting with thallium for multi-dose activated charcoal because you usually learn that there's no benefit of charcoal in metals, but this is one where there's some enterohepatic recirculation and maybe you're just like pushing the bile further down the tract and keeping it from getting reabsorbed. But yeah, well, that's a good one.
Hate
Yeah,
that.
alopecia, abdominal pain, neuropathy, and mad roommates. Very good. Okay. I got a special one cooked up just for you.
Bring it.
A 51-year-old male presented to the emergency department with sore throat and vomiting after he ingested a drink given to him by his girlfriend. It was a liquid mixed with another chemical. He was treated and released, but the sore throat and vomiting persisted. And after 8 days, he developed new onset shortness of breath. Then, 4 days after the development of shortness of breath, he presented to the emergency department again. So this is now 12 total days from exposure and 4 days since he developed shortness of breath. So vitals on admission: blood pressure 132/75, heart rate 96, respiratory rate 21, setting 90% on 65% FiO2. Labs from admission: BUN 74, creatinine 2.9. He does have a past medical of chronic kidney disease and methamphetamine usage. Physical exam: he had no GI symptoms. It's noted he had no chemical burns and nothing else abnormal. So the patient on admission was treated for community-acquired pneumonia with antibiotics. And
What did his chest x-ray show?
chest x-ray was consistent with pulmonary fibrosis and pneumonia. He did require intubation on it at this time. So right away, pretty much when he represented.
I know what it is.
Would you like to run through some differential?
No, I know what it is. Keep going.
All right. I'll keep going. After intubation, he was not improving. They did a CT 10 days later of the patient's chest, which demonstrated ground glass opacities and severe bilateral lower lobe infiltrates with mild emphysema. He remained intubated on propofol, became hypertensive, febrile, on antibiotics, and he died 28 days following exposure.
Paraquat.
Yes, this is paraquat.
Paraquat's super interesting. But it's really weird that if this was a U.S. case, we don't really know, right? Because it's not.
That's true.
It's an herbicide, but it's not utilized here or sold in the U.S. or available in the U.S. So, but I initially was like, what did he drink? And then trying to think of a delayed respiratory poison. There's not a lot of them. And usually the delayed part is like 24 to 48 hours, not like a week later. So
that's usually inhalation, not ingestion. Too.
Right. So, yeah. Well, then oxygen makes it worse because it just drives the free radical, pathway of destruction. Right.
So for the listeners, this is a herbicide of near mythical legend within the toxicology community that it's a massive free radical producer. It's called a bipyridal. Basically, it makes its ways into your organs and just cycles electrons around, crushing all cellular machinery around you, generating reactive oxygen species. And it's one of the poisons where oxygen can make it worse because you're increasing free radical oxygen production. Hallmark toxicity being that you can actually have very delayed toxicity from it. You see multi-system organ failure. Treatments are usually, there's a million different things that have been looked at. Antioxidants, prednisone and cyclophosphamide are two I know that kind of get looked at. And this case states, on day 23, the treating team was informed of the history of paraquat exposure, but prednisone and cyclophosphamide were not started due to concern for infection. So that's why they didn't do that.
Stupid.
And there's basically, there's like a paraquat nomogram out there. And it's basically
Really?
like, yeah, and it's basically like, no matter where you end up on the chart, you're going to die. So it's a very lethal poison. And they do note here no GI burns, although I don't think they look for it. But yeah, it can be, I think, a little caustic as well, possibly.
I wonder what happened to his girlfriend.
I don't know. But yeah, this could have been just a simple mistake.
Doubtful.
Oh, so here's the autopsy finding. Lungs had diffuse fibrosing process with gross obliteration of the normal architecture. Wow. Microscopic evaluation demonstrated obliteration of alveolar spaces by fibroblastic proliferation, thickened septae containing fibrosis, and then extravasated red cells and hemoceratin deposition. There were tracheal and tongue ulcerations. So he did have, well, he was also intubated for a long time, but I assume. Yeah. Okay. Do we have another case?
I do. I thought this was more interesting from a treatment standpoint.
Yeah. We should talk about treatment too.
All right, you're right. So this is a 70-year-old female patient. Mm-hmm. She was at an outpatient surgical center for hemorrhoidectomy.
Oh boy.
Yeah. So she ended up developing VTAC after getting a local anesthetic. Her past medical history is hypertension, coronary artery disease, hyperlipidemia, and anal carcinoma. Her blood pressure was 180 over 130. Her rate was 140. She was in VTAC. Her lungs on exam had pulmonary edema. So in the ED, she was intubated.
Okay.
They gave her metoprolol and esmolol.
Huh.
She was still sinus tachycardia, a heart rate of the 140s to 150s. They started a nitroprusside infusion.
What?
She became bradycardic, went into VFib, had a PEA arrest, and then died.
All right. Well, I have multiple questions. You didn't get bicarb or lipid?
Nope.
Okay. So she went in for a hemorrhoidectomy, presumably got a local anesthetic, which is going to be either probably lidocaine or bupivacaine, perhaps. These are class 1 sodium channel blockers, which we would know are going to delay sodium currents and cause widening of our QRS. And thus, you're going to have a wide QRS tachycardia. Normally, when we have VTAC, in her case, she would be considered, I guess, I don't know much about her physical exam, but she has a good blood pressure, a very good one, scary one. So I guess you could maybe classify her as stable I'm assuming it was monomorphic VTAC, in which case your options would be shocking. You could consider adenosine, procainamide, or amiodarone, but in this case, a tox-induced wide complex tachycardia, you're not going to use an antiarrhythmic. Usually, we're not going to use like a sodium channel blocker to treat a sodium channel blocker. So in these cases, we usually try to overwhelm the sodium channel blockade with sodium. So she never received any hypertonic sodium of any kind?
Nope.
Okay. And she wasn't ever shocked?
Go back to the beginning where you said presumably. She got...
Okay, presumably she got...
Presumably.
Okay.
She got a local anesthetic.
So did she not get a local? This was hemorrhoid-induced VTAC?
Yes, her hemorrhoids caused her VTAC.
Yeah.
So the physician was passed a syringe.
Oh. And she was treated with nitroprusside, and she was treated with metoprolol. So the physician was probably passed a syringe of ephedrine, would be my guess.
Yeah. Or a 1 to 1,000 dose of epinephrine.
Of epi, okay.
She got 30 milliliters.
Wow. So she got 30 milligrams of epinephrine? 1 to 1,000? No, she got 3 milligrams. This is why 1 to 1,000 is dangerous terminology. We need to get rid of it. It's 1 mg per mil. Okay. She got 30 milligrams. Wow. So she was given 30 milligrams of epinephrine, tachycardic. They started on nitroprusside. They beta blocked her. That makes sense. They probably should have done labetalol, but I get why they did esmolol. Wrap it on, wrap it off.
Yeah, nitroprusside was interesting.
Phentolamine is probably what I would have gone with and not nitroprusside, or something like a pure alpha blocker. So what they were doing was treating excessive vasoconstriction by attempting to veno and vasodilate. But the vasoconstriction is coming from alpha agonism. Yeah. So I would have probably tried to just block the alpha receptor. You know?
But also her blood pressure wasn't like
it wasn't like that. It was like 180. No.
Yeah. So I mean her diastolic was 130, but
yeah.
I mean well, that's only one value, right? Like we don't know where she was at throughout the whole thing. Like she probably was higher. But yeah, I don't know. I thought
I just like read this a couple of times and I was horrified. Like, could you imagine just getting passed the wrong syringe? We've had so many, drug shortages lately that every vial is different than what you're normally used to seeing. And like, yeah, it could happen to anybody. Like, how horrifying would that be if that was you? And then like, how do you treat that? Like, I just thought that it was an interesting case. It's not that.
It does bring up, iatrogenic toxicity or hospital-induced toxins are very common, unfortunately.
I actually had a nurse, we were going to put a hip back in an elderly woman, and she pushed 300 milligrams of propofol instead of 30. There was a tenfold dosing error. She didn't read the bottle or the concentrate. And I was a resident, so I didn't pay attention that she had a 30 ml syringe in her hand. So this woman went apneic real fast. Thankfully we bagged her out of it. We didn't even intubate her because it wore off so quickly. But now anytime I do a conscious sedation, I double check the bottles. I see what the nurse pulled up. I say the dosing out loud. I say the concentration. And I think it just takes one of those to scar you for life.
Yep.
Yeah.
It can't be too safe in the emergency department. Great case. Interesting. Still advocating for phentolamine, but I think, or Lambator.
Yeah.
I don't know. I get why they did Esmol, but they didn't have any alpha blocking. I don't know. I thought it was going to be maybe benzocaine methemoglobinemia worsened by nitroprusside because nitroprusside can cause
that would have been fun.
That would have been wild. But it wasn't. So
it was
not. Okay, I have. You want to do one more? How do you feel?
We can do one more.
Okay. This one I think is a good one. We have a 69-year-old female made a tea with leaves from a plant in her garden, thinking it was safe, and later developed nausea, vomiting, and diarrhea.
It's never safe, lady.
It's not for anyone. The best way to get sick from plants is to hyperconcentrate all the alkaloids in them into a solution and then drink it. Physical exam, blood pressure 153/76, heart rate was 30 and irregular. Respiratory rate was 20. Oxygen 93% on room air. Temperature normal. Her potassium was 6.6.
Oh my God, she drank some foxglove.
All right. We don't know that it was foxglove. But her digoxin level was 55.5 nanograms per milliliter.
Get out. Or she did oleander.
Yeah.
Or lily of the valley. Or she licked a toad.
She could have had some bufo.
Bufo.
My favorite cardiac glycoside containing tree or plant would be the pong pong tree, because I love the name.
You just like
also known as the suicide tree, which is a little bit darker, but I really like
I like the first name better.
Yeah, I agree.
Did they use up all of the Digibine in the hospital?
They don't say how much she got. She got atropine. She became more bradycardic, received increases doses of dopamine without improvement. The patient deteriorated, requiring ACLS and intubation. She got Digifab. Her serum K increased to 8.2 despite treatment.
Ooh.
Pacemaker did not capture. CPR and repeated cardioversions were performed. She developed multiple episodes of torsades and died 24 hours after.
That is crazy.
So how much, here's my question to you, how much Digifab would you give her?
Well, they say after, right, if it's an empiric unknown ingestion, so I'm assuming that she probably came in like that.
Mm-hmm.
I wonder if they had the level back before they would do it.
They
right?
didn't have they just gave it. It said it gave it empirically. So there's no way. If you have someone arresting.
10 vials is what you're supposed to do.
Yeah.
Right?
Yeah.
But
if you follow the adage of level times weight divided by 100.
Yeah.
If she was a 70-kilo patient, we'll just assume.
Just make her 100. The math is easier.
All right.
She would need 55
vials. I mean,
Jeez.
that's insane.
But if you think about it, that's how sick she was. Like her potassium went up to 8.
Yeah, she was quite ill. And she had some of the textbook things: irregular bradycardia, slow AFib, or AFib with slow ventricular rate is somewhat textbook, as well as biventricular VTAC are kind of. I think there's some good stuff in this case. First, it talks about some of the initial symptoms you see with DIG toxicity, which is, we always think cardiac, but nausea, vomiting are very common, especially in chronic.
I bet she saw yellow halos.
Right. She probably had xanthopia or xanthopsia, whatever. Everything was yellow. She had halos. And in fact, whenever I see patients, and even back when I was at Walgreens counseling patients, I would always ask them if they saw any halos or vision changes when they pick up their DIG. This is a good way to tell, are maybe they're dosed too much, it's a good reminder for them. And then her K was elevated. So DIG, for the listeners, sodium potassium ATPase inhibitor, literally the most vital pump in all of our body. It's what keeps sodium outside your cell and potassium in your cell and establishes those gradients that are so important for life that we've talked about in past episodes. So if you inhibit that sodium potassium ATPase pump, sodium starts to go in the cell and potassium starts to leave the cell. So you see hyperkalemia, and there's more sodium in the cell, so they're more positive. They depolarize easier, so you get increased automaticity of the vagus nerve, which can cause bradycardia. Pretty interesting. Would you treat her hyperkalemia with calcium?
Yes.
Are you a believer?
Is a myth. It's a truth. Truth. To quote Frank Polachek from UIC, it is a truth or a myth that has been propagated as a truth.
I would like to point out that Matt also quoted Frank Polachek on the last episode, so he's now been quoted.
Did he? Because Frank's famous. Love him.
Yeah, I agree. I think Stoneheart's got nothing really to stand on. There's not a lot of good data for that.
Yeah.
All right. Well, that was great. Any words of wisdom you want to leave with our listeners, or just life wisdom?
My words of wisdom are: listen to your bad jujus. Pharmacokinetics are not toxicokinetics. Supportive care and benzos will get you through most, except for aspirin poisoning. So know that one.
Those are good. Those are all very good.
I don't have any life advice. But I will say this. That if you're in academics or find yourself working too much, you should quit one thing and do a fun thing. Because I quit the IRB and signed up for piano lessons.
Oh, yeah.
Yeah.
And that rhymes. Quit one thing, do a fun thing.
Yeah, exactly. And it was very hard to do. It was really hard to do. But it was one of the best life decisions I've ever made. And I had my first piano recital in my life as a 41-year-old last week.
That's fantastic.
But it's fun.
That is great advice. Sage wisdom from our excellent guest, Dr. Jillian Theobald. Thank you for being on the show today. I think that'll wrap it up for today. No, honestly, thanks for being on. This was really fun. I had a good time.
Of course.
Some great
Thanks for having me.
Wow, Ryan, I really liked her on the show.
Yeah, that was a great show, wasn't it? Hey, thanks for listening along, Toxo. And for everyone out there, that's going to wrap it up for today. Just giving a reminder that if you liked what you heard today, feel free to follow us on iTunes, Apple Podcasts, Google Podcasts, whatever podcast thing you like to listen to. We're there. And don't forget to follow the show on Twitter. We can follow the show at Lab Poison, myself at EMPoisonPharmD, and Instagram at Tox_talk. And we even have a Facebook page. Feel free to throw a like there, or whatever it is people do on Facebook. And most importantly, don't forget to reach out to the show, toxtalk1@gmail.com. I am going to play the clip to our next episode. If you think you know what's going on, I need you to send in your guesses so that we can talk about them in the beginning of the next episode. Toxo, would you mind playing the clip? A married couple in their 40s presents to the emergency department. Each patient is displaying signs of an inferior wall myocardial infarction or heart attack with ST segment elevations in the inferior leads of their EKG. They each have hypotension with systolic blood pressures in the 70s and bradycardia with heart rates in the 30s to 40s. The bradycardia and hypotension immediately resolves after atropine. They're taken to the cath lab to treat their suspected heart attack, but no heart attack can be found. No coronary arteries are blocked. The couple revealed that they had recently purchased a natural, sweet-tasting food that was touted as a sexual performance enhancer. The couple had been ingesting 1 teaspoon of the substance each day for the last week, but before presenting to the emergency department, they increased their dose to a full tablespoon, which led to them both showing false signs of a heart attack and severe, life-threatening hypotension and bradycardia. That'll wrap it up. Don't forget to send your guesses. Thanks for listening today. Hope to see you next time. Toxo, play us out.
Information on this show is for educational purposes only and should not be interpreted as medical advice or treatment recommendations. Please contact your doctor for any health questions or call your local poison center at 1-800-222-1222 for poison-related questions. The opinions expressed on this podcast do not represent those of our employers. This show is poorly written and shoddily produced by Ryan Feldman. Subscribe for future episodes and don't forget to share with your nerdy friends. See you next time. Goodbye.